All right, I'd like to introduce our next speaker, speaking on surgical considerations to transplant. Dr. David Kaczorowski. He is an associate professor of cardiothoracic surgery and the surgical director of the Advanced Heart Failure Center at the UPMC Heart and Vascular Institute here in Pittsburgh. And he will be speaking to us virtually here today.
Hello, my name is David Kaczorowski, and I'm the surgical director at the Advanced Heart Failure Center at the University of Pittsburgh Medical Center. I'm an associate professor of cardiothoracic surgery in the Department of Cardiothoracic Surgery, and I work closely with our congenital heart surgeons to do the adult congenital heart transplants at the University of Pittsburgh. And I greatly appreciate their collaboration on that, and with that, I believe we've been able to achieve some very good outcomes. I've been asked to discuss surgical considerations to transplant in the Fontan-Kreutzer patient, and that's the focus of my talk today. So it's clear that long-term survival in patients with single ventral congenital heart disease can be commonly achieved with staged Fontan palliation. However, it's also clear that late morbidity and mortality can occur through a number of different mechanisms. These can include Fontan pathway dysfunction, systemic ventricular dysfunction, extracardiac dysfunction, including liver dysfunction and renal dysfunction. It can also include lymphatic dysfunction resulting in protein-losing enteropathy or plastic bronchitis. And some have suggested that advanced heart failure consultation should be considered when these things occur. And it's clear looking at ISHLT data why in adult patients transplantation might be an attractive option for patients that have late complications. Specifically, we know from ISHLT data that although there is a fairly high perioperative mortality in patients with congenital heart disease, there's really excellent long-term survival. This is even more clear when we look at survival conditional on 1 year survival. And specifically in this case, patients with congenital heart disease, denoted here by the yellow line, actually have the very best survival compared to other groups. Now, it's also clear that stage palliation for single ventricle hearts can cause a number of issues for transplantation down the road. Specifically, in order to perform this sequence of operation, multiple sternotomies is required. There may be construction of a neo-aorta, and there's surgical manipulation of the pulmonary arteries. This may include a VT shunt, a Sano shunt, and of course, Glenn and Fontan anastomosis. So this sequence of operations can result in a number of challenges. And one of these challenges is sternal reentry. When we look at patients that have had single ventricle palliation and specifically those with neo-aorta reconstruction, we can often see aortic dilatation, and this aorta may be just underneath the sternum, and the heart and other structures may be densely adherent to the sternum underneath. This can create a dangerous situation when we attempt to re-enter the mediastinum. Some have advocated the use of cannulation of peripheral vessels and early institution of cardiopulmonary bypass to help mitigate these risks. Other challenges include the presence of collaterals. We know that one of the things that's difficult about these operations is that intraoperative and perioperative bleeding may occur, and this is really a major source of morbidity. There may be veno-venous and or aortopulmonary collaterals, which may be present, and these can result in bleeding during the mediastinal dissection. So it's clear that meticulous attention to hemostasis is crucial, and awareness of the presence of these vessels is important. As I mentioned, there may be aortic dilatation. There may be also calcification of the neo-aorta. And the aortic dilatation, again, can be a problem as it may necessitate replacement of some of the ascending aorta or aortic arch. Again, it may create a dangerous situation for sternal reentry. In addition, aortic calcification may create a difficult situation when attempting to anastomose the donor aorta to the recipient aorta. And in each of these situations, it may be necessary to perform an ascending aortic replacement and or hemi-arch. As I mentioned, the pulmonary arteries may be manipulated. There may be an atriopulmonary connection. There may be a lateral tunnel, total cavopulmonary connection. There may be an extracardiac conduit. In each case, there is manipulation of the pulmonary arteries, and this may result in stenosis, and the pulmonary arteries may or may not have been stented. In any case, the pulmonary arteries may be patched or entirely reconstructed. There may also be anatomic variation, including variation in the position of the great vessels, as shown here, with the PA stump to the right of the aorta. There may also be dextrocardia or situs inversus. There may be venous anomalies or other anatomic variations. All of these challenges represent challenges to the mediastinal portion of the operation, but in addition, these patients may have cirrhosis, which can result in coagulopathy due to impaired synthesis of coagulation factors and thrombocytopenia. There may be also venous collaterals or varices that can be prominent. These can result in bleeding as well. In some cases, a combined heart-liver transplant may be necessary, and this can be either performed sequentially or en bloc. These issues were summarized nicely by Konstantinov and colleagues in this figure that was published in JTCVS Techniques in 2022. The authors illustrate here that, again, there can be manipulation of the pulmonary arteries with the Glenn and Fontan itself. There may be neo-aortic dilatation. The PAs may be stented. I didn't discuss this, but a left ventricular assist device may or may not be present. And there may be anomalous venous anatomy, including the presence of a left-sided SVC. So again, this may necessitate a variety of things that complicate the operation. There may need to be ascending aortic or hemiarch replacement, or as illustrated here, total arch replacement. The PAs may need to be patched, as I said, or also simply replaced with a tube graft. And there may need to be venous reconstruction as well. Then the heart can ultimately be transplanted in really a normal fashion, but this does involve a significant amount of operation, which then necessitates longer cardiopulmonary bypass times and may result in longer ischemic times as well, which may not be good for the graft. There can also be a number of other challenges. These include things like protein-losing enteropathy, renal dysfunction, an elevated pulmonary vascular resistance, and there may be challenges diagnosing that. Patients may have muscle wasting, and they may also have preformed antibodies. On top of that, the adult heart transplant allocation system was revised in 2018, and it was revised from the old system, which was essentially a three-tiered system, status 1A, 1B, and status 2, to a six-tiered system, status 1 being the highest and 6 being the lowest. And patients that were most acutely ill were essentially allocated to the first status. Many of those patients may require VA ECMO, but they must meet hemodynamic criteria. Patients with congenital heart disease, including patients with Fontan circulation, are status 4 in this allocation system. And it can be challenging to obtain high quality hearts for patients that are status 4 in the system. So it's clear that staged surgical intervention for single ventricle hearts can result in a number of challenges to subsequent heart transplantation. So what are the outcomes after cardiac transplantation in Fontan patients? Simpson and colleagues looked at outcomes after pediatric heart transplant in the pediatric heart transplant study database. This database is housed at the University of Alabama, but includes data from 38 centers, at least at the time of this publication, and these are located across the United States, Canada, and the UK. Previous work had demonstrated a relatively high post-transplant mortality in Fontan patients undergoing heart transplant, most of which was in the early perioperative period. And so Simpson and her co-investigators divided these patients into early and late cohorts. The early cohort was between 1993 and 2006, and the late cohort was between 2007 and 2014. The patients in the late cohort had a slightly higher incidence of renal insufficiency, although this did not reach statistical significance. They did have a higher incidence of protein-losing enteropathy, which did reach statistical significance. There was also a significantly higher proportion of patients with failure to thrive in the late cohort, and the patients in the late cohort were more frequently supported with inotropes, whereas the patients in the early era were more commonly on a ventilator at the time of transplant. They also compared patients with other forms of congenital heart disease to those with Fontan circulation. And when they looked at these groups, they found that there was a slightly higher incidence of renal insufficiency in the Fontan patients, although again, that did not reach statistical significance. There was certainly a higher incidence of protein-losing enteropathy, also a higher incidence of failure to thrive, again, not reaching significance here. There was a significantly higher incidence of inotrope use in the Fontan group, and the non-Fontan patients had a higher incidence of ventilatory support. I'll also point out that as we discussed, and as you might expect, the ischemic time was longer in the Fontan patients, although not significantly longer from a clinical standpoint, although it did reach statistical significance. There was a higher percentage of patients that had an ischemic time longer than 4 hours as well. So when they looked at the outcomes in each of these eras, the early era and the late era, what they found is that there was a high hazard for mortality in the early perioperative period, and this leveled out. This is what has been seen previously. The 1-year survival in the early era was 77%, compared to 89% in the more recent era. And now, when they compared the patients that had Fontan circulation performed in the early era, it was seen that these had the worst overall survival with a high perioperative mortality. This certainly improved in the more recent era and was much closer to what was observed with other patients with congenital heart disease in both eras. In terms of causes of death, infection was a major cause of death in both eras. Around 20% of patients died from infection. Acute rejection was actually a significant cause of death as well, causing death in 14% of patients and just over 11% in the late era. And then sudden cardiac death was high in the early era, 14% versus only 3% in the late era. Other causes of death accounted for 30%. Or roughly 30%, both groups, and some of these were likely due to multi-organ failure in the perioperative period. Mertuzza and colleagues also looked at outcomes in patients with Fontan, but they looked at survival of adult patients undergoing cardiac transplantation at a single center. And what they found is that the mortality of patients with Fontan circulation was very high and was over 30% in the early perioperative period, although they did have a fairly high mortality of non-Fontan patients as well. What they found also was that the incidence of heterotaxy was much higher in non-survivors, and the MELD score was also much higher in non-survivors in their series. In an overlapping cohort of patients, Cardoso and colleagues looked at outcomes in patients undergoing transplantation. These are adult patients with failing Fontans, and asked what we could potentially do better. And so when they looked at these patients, again, they observed a fairly high perioperative mortality, in the neighborhood of 30%. And then they stratified by the presence or absence of major intraoperative bleeding, and they found that there was an extremely high mortality in patients with major intraoperative bleeding and a much lower mortality in patients that did not suffer from major intraoperative bleeding. They identified this as a major target for improvement in these patients. Now, this was a slightly flawed definition. They used the number of packed red cells as one criterion for the diagnosis of major intraoperative bleeding, but also the need to go back to the operating room. And importantly, the presence of an open chest was used as a defining criterion for major intraoperative bleeding. So you could imagine that patients with significant right heart dysfunction may also fall into this group. But I think the data does demonstrate that major intraoperative bleeding is certainly a problem, and if we can avoid that, we can potentially do better with outcomes in these operations. Jonathan Menachem and his group looked at outcomes in adult heart transplant patients, this time using the nationwide inpatient sample database. And so they looked at inpatients between 2004 and 2014 who underwent transplantation with a diagnosis of single ventricle. And what they found is that overall, the mortality was 5.4% in the cohort of patients they looked at. Of those that had a Fontan, as compared to other adult congenital patients, the mortality was 26.3%. So there was a odds ratio of 18, and this did reach statistical significance for the presence of a Fontan. The rate of major bleeding was also much higher in patients with a Fontan, and the use of ECMO was also substantially higher in patients with a Fontan. And again, both of these reached statistical significance. So what can we do to optimize these outcomes as outcomes for heart transplantation in adults with Fontan are clearly not optimal. There are a number of things that can be done. Some of them I've listed here, but clearly from a pre-transplant standpoint, we definitely want to perform imaging to define the anatomy, including the great vessel arrangement and venous anatomy. It's important, I think, to document the vascular access, as well as get the best assessment of the PVR that's possible. I think it's important to assess hepatic function in the presence of cirrhosis. And it's also important to assess whether the patient is sensitized or not and have a strategy to deal with that, and as much as possible to optimize the nutritional status. For our donor selection, we avoid undersized donors, and I think that is largely agreed upon. Marginal donors with marginal LV or RV function should probably be avoided, and extra length on donor vessels can be useful as well. From an intraoperative standpoint, we've already touched on some things, but I think coordination is of the utmost importance. I think it's important to allow extra time for insertion of lines, anesthesia, and the initial dissection. Because the sternal reentry can be problematic, it's probably advisable to have peripheral access available. If the initial sternotomy and dissection can be performed off of bypass without the administration of heparin, that may be beneficial since the patient won't be anticoagulated, but if it's necessary, it is. The pulmonary venous return from these collaterals may also be unusually high, and cooling can be very useful, as well as additional venting. And then, as we discussed, deep hypothermic circulatory arrest may be necessary for aortic reconstruction, or if there's significant injury on reentry. Certainly there are many others, but some of these things may help us optimize outcomes as we approach these patients. There are a number of alternatives to transplant. Konstantinov in his JT-CVS techniques outlined a number of potential ways that ventricular assist devices can be utilized, and some of this has been discussed already today. And Dr. Morell will be also discussing some other alternatives to transplantation in his talk. So in summary, I think we can say that the long-term survival in patients with single ventricle congenital heart disease is commonly achieved with stage Fontan palliation, but there is late morbidity and mortality that can occur through several mechanisms, and heart transplant is one treatment option when this does occur. Stage palliation for single ventricle hearts requires multiple sternotomies, surgical manipulation of the pulmonary arteries, and may involve neo-aorta reconstruction. This process results in a number of challenges to transplant, including mediastinal adhesions, aortic dilatation, calcification, collaterals, and the potential need to reconstruct the pulmonary arteries and others as well. Outcomes for pediatric patients undergoing heart transplant are comparable to those with other types of congenital heart disease and have improved over time. However, mortality after heart transplantation in adults remains high, but this can be in part mitigated by careful pre-transplant preparation, donor selection, and intraoperative management, including the avoidance of major bleeding. Thank you for your attention, and this is my email address. I'd be happy to discuss this further or take any questions. Thank you.